Lời đầu tiên, thay mặt ban tổ chức, xin gửi lời chào trân trọng đến quý thầy cô, quý đại biểu hiện đang có mặt tại hội trường khách sạn Novotel, quý đại biểu đang tham dự qua 11 điểm cầu online và hơn 1.500 đại biểu đang có mặt tại các điểm cầu online khác trên cả nước đã dành thời gian quý báu của mình đến tham dự hội thảo chuyên đề thực hành lâm sàng dựa trên bằng chứng y khoa trong quản lý các bệnh lý sản phụ khoa thường gặp. Chương trình được phối hợp tổ chức bởi Hội Phụ sản Việt Nam Vago, Bệnh viện Phụ sản Nhi Đà Nẵng cùng với sự đồng hành và hỗ trợ của Văn phòng đại diện Business Healthcare Việt Nam hôm nay ngày 10 tháng 5 năm 2026. Kính thưa quý đại biểu, với mục tiêu cập nhật không chỉ là chứng cứ lâm sàng trên thế giới mà còn là những hướng dẫn thực hành tại Việt Nam, chương trình hội thảo hôm nay là cầu nối khoa học tin cậy để quý bác sĩ cùng nhau thảo luận, đúc kết kinh nghiệm, áp dụng vào thực hành lâm sàng nhằm nâng cao chất lượng chăm sóc tại cơ sở y tế của mình. Tham dự vào buổi hội thảo hôm nay, chúng tôi xin trân trọng giới thiệu sự hiện diện của ban chủ tọa và các báo cáo viên. Xin trân trọng giới thiệu chủ tọa, tiến sĩ bác sĩ Trần Đình Vinh, Giám đốc Bệnh viện Phụ sản Nhi Đà Nẵng, thành viên Ban chấp hành Hội Phụ sản Việt Nam Vago. Xin trân trọng giới thiệu giáo sư Giancarlo Di Renzo, Giám đốc Trung tâm Y học Sinh sản và Chu sinh Đại học Perugia, Ý, nguyên thư ký Liên đoàn Sản phụ khoa quốc tế, Giám đốc Đại học trường Brain School. Xin trân trọng giới thiệu bác sĩ chuyên khoa 2 Phạm Hồ Thúy Ái, trưởng khoa hiếm muộn, nguyên trưởng đơn vị kỹ thuật chẩn đoán Bệnh viện Từ Dũ. Và bác sĩ chuyên khoa 2 Nguyễn Bá Mỹ Nhi. Bác sĩ Mỹ Nhi đang trên đường đến với hội trường ạ. Tham gia vào buổi hội thảo ngày hôm nay, chúng tôi cũng rất hân hạnh được chào đón sự hiện diện của hơn 150 bác sĩ sản phụ khoa tại khu vực Đà Nẵng và các khu vực lân cận đang có mặt tại hội trường khách sạn Novotel Đà Nẵng, cùng với 200 bác sĩ tại 11 điểm cầu online và hơn 1.500 chuyên gia sản phụ khoa hiện đang tham gia qua nền tảng Zoom trực tuyến trên khắp các điểm cầu cả nước. Về phía đơn vị tài trợ, chúng tôi xin trân trọng giới thiệu sự hiện diện của thạc sĩ bác sĩ Nguyễn Thành Danh, trưởng đại diện Văn phòng Business Healthcare Việt Nam. Kính thưa quý bác sĩ, buổi hội thảo hôm nay có cấp chứng chỉ CME cho bác sĩ tham dự. Điều kiện để cấp chứng chỉ CME cho đại biểu tham dự online và trực tuyến qua các đầu cầu như sau. Bác sĩ có đăng ký thông tin tham dự trước hội thảo và tham gia trên 80% thời lượng chương trình cũng như trả lời đúng 80% số lượng câu hỏi post-test. Quý bác sĩ sẽ nhận được đường link câu hỏi post-test trong khung chat và mã QR code trên màn hình vào cuối chương trình. Quý bác sĩ vui lòng tham gia bằng email đã đăng ký cho ban tổ chức để có cơ sở ghi nhận và cấp CME. Kính thưa quý vị đại biểu, để mở đầu cho chương trình hội thảo hôm nay, chúng tôi xin trân trọng kính mời tiến sĩ bác sĩ Trần Đình Vinh, Giám đốc Bệnh viện Phụ sản Nhi Đà Nẵng, thành viên Ban chấp hành Hội Phụ sản Việt Nam Vago, sẽ có đôi lời phát biểu khai mạc. Xin trân trọng kính mời tiến sĩ bác sĩ Trần Đình Vinh.
Giáo sư Di Renzo, thưa bác sĩ chuyên khoa 2 Phạm Hồ Thúy Ái, thưa anh Thành Danh bên hãng Business Healthcare, thưa các quý thầy cô và các anh chị đồng nghiệp. Hôm nay bên ban tổ chức có chuẩn bị cho tôi một cái tài liệu để chuẩn bị cho cái hội thảo ngày hôm nay và đã chuẩn bị rất là công phu. Tuy nhiên trong cái quá trình tổ chức thì mình nhận ra một điều đặc biệt của ngày hôm nay. Thưa các anh chị, ngày hôm nay là ngày mùng 5 tháng 5 năm 2026 và trong những năm gần đây đó thì có một cái ngày lễ vô cùng đặc biệt, đấy là ngày của mẹ. Chính vì vậy mà mấy anh chị ở bên ban tổ chức cũng gợi ý để hôm nay cũng muốn giới thiệu với lại quý thầy cô với các anh chị hội nghị để nhằm tôn vinh ngày của mẹ, một ngày rất là đặc biệt. Thì thưa các anh chị, hôm nay chúng ta cùng nhau có mặt với một chủ đề rất thiết thực là thực hành lâm sàng dựa trên bằng chứng trong các quản lý bệnh lý sản phụ khoa thường gặp. Tôi cho rằng đây không chỉ là một buổi cập nhật kiến thức mà còn là dịp để nhìn lại và điều chỉnh cách tiếp cận thực hành hàng ngày. Trong nhiều năm qua, ngành sản phụ khoa đã có những bước tiến triển rất là tốt đẹp. Chúng ta không còn chỉ điều trị khi bệnh xảy ra mà phải chủ động nhận diện nguy cơ và can thiệp từ sớm. Điều này thể hiện rõ trong cả 3 nội dung của chương trình ngày hôm nay. Thứ nhất là chương trình đối với trong thai kỳ thì việc quản lý các bệnh lý như là sảy thai, sinh non hoặc tiền sản giật không còn được nhìn nhận là các bệnh riêng lẻ mà là các hội chứng đa cơ chế. Điều đó đòi hỏi chúng ta phải thay đổi cách tiếp cận từ xử trí biến chứng sang quản lý nguy cơ ngay từ đầu thai kỳ. Trong lĩnh vực quản lý HPV, chúng ta cũng đang chuyển từ theo dõi thụ động sang can thiệp có mục tiêu, đặc biệt là đối với các nhóm nguy cơ tồn lưu nhằm giảm nguy cơ tiến triển đến tổn thương cổ tử cung. Và cuối cùng, chủ đề thứ 3 ở trong buổi hội thảo, đấy là đối với lĩnh vực mãn kinh. Một trong những thay đổi quan trọng nhất là việc gỡ bỏ những rào cản tâm lý đối với liệu pháp nội tiết. Điều trị hormone thay thế ngày nay không còn là một liệu pháp cần phải e ngại, mà là một phương pháp điều trị hiệu quả nếu chúng ta sử dụng đúng, chỉ định cũng như cá thể hóa tốt cái trường hợp bệnh lý, theo dõi và điều trị. Và điểm chung lớn nhất của 3 nội dung hôm nay, đấy chính là sự thay đổi trong tư duy lâm sàng. Chúng ta chuyển từ tiếp cận bệnh sang tiếp cận theo nguy cơ. Chúng ta chuyển từ điều trị triệu chứng sang can thiệp vào cơ chế bệnh. Và quan trọng nhất là chuyển từ phác đồ điều trị đồng loạt sang cá thể hóa điều trị cho từng bệnh nhân. Tôi hy vọng rằng với các quý thầy cô có các kiến thức về lâm sàng và giảng dạy nhiều năm sẽ không chỉ cập nhật các kiến thức mà có thể mang đến những cái thay đổi cụ thể trong thực hành, từ cách đánh giá bệnh nhân, chỉ định điều trị đến theo dõi điều trị lâu dài. Và tôi tin rằng các đại biểu tham dự hội nghị hôm nay sẽ thu hoạch được những kiến thức tốt đẹp phục vụ cho công tác của mình. Một lần nữa xin kính chúc hội thảo của chúng ta thành công tốt đẹp và có được những trao đổi khoa học thật nhiều giá trị. Xin trân trọng cảm ơn.
Dạ, xin trân trọng cảm ơn phần mở đầu của tiến sĩ bác sĩ Trần Đình Vinh. Kính thưa quý đại biểu, mở đầu nội dung khoa học của chương trình hôm nay là bài báo cáo với chủ đề Progesterone trong phòng ngừa hội chứng sản khoa nghiêm trọng, cơ chế và bằng chứng lâm sàng, được chia sẻ bởi giáo sư Giancarlo Di Renzo. Bài báo cáo được dịch thuật song song cùng với sự đồng hành của phiên dịch viên bác sĩ Đặng Tuấn Anh. Quý bác sĩ tại hội trường muốn nghe phiên dịch tiếng Việt, vui lòng sử dụng tai nghe để tại ghế ngồi. Quý bác sĩ tham dự online, vui lòng chọn thông dịch ngôn ngữ và chọn tiếng Việt hoặc làm theo hướng dẫn trên màn hình Zoom. Xin kính mời giáo sư Giancarlo lên sân khấu để bắt đầu phần trình bày của mình ạ.
Okay, yes. So, good afternoon. Thanks very much for having me here with you. And the best wishes to all the mothers which are present, because it's the Mother Day. I'm coming from Italy, as you know, but I'm frequently in Vietnam. I have many friends which I acquired in the last 15 years, and I'm very happy to be always in your beautiful country. So you see, I'm coming from Perugia mainly, but my activities are mainly in the city of Florence and in London, where I have some activities, you know, with the FIGO and with the Global Library. I have no particular conflict of interest to declare today. Therefore, I want to enter in the discussion of this topic. One of the big problems we have in obstetrics still is the current taxonomy of disease in obstetrics. It mainly refers to clinical presentation. I give you just an example. Preeclampsia is referring to the combination of two signs, the hypertension and the proteinuria. It's not addressing the etiology of the problem. If we go in the clinical department, for instance, for infectious disease, we cannot say that the diagnosis is a cough, because cough may depend from pneumonitis, and even pneumonitis is not enough. Pneumonitis may be derived from a cytomegalovirus. So the final diagnosis, if you go in infectious disease department, is pneumonitis from cytomegalovirus. However, we still are back to only the clinical presentation, and we don't address the mechanism of disease. This is a big challenge for making prevention and prediction. So, a few years ago, along with Professor Romero, we pushed forward the denomination of great obstetrical syndrome or syndromes for many of the diseases which are responsible for maternal, fetal, neonatal high degree of mortality and morbidity. We published this in the Black Journal in 2009, as you see, and we represented that the obstetrical syndrome have 5 features, very important, which can be found in the most of the diseases which happen in pregnancy. They have multiple etiologies, so they are multifactorial. They have a long preclinical stage. For instance, preeclampsia develops as hypertension and proteinuria after many weeks that the disease started in the placenta, probably. There is a fetal neonatal involvement. For instance, in preeclampsia, we may have growth restriction of the baby. This predisposition, there is predisposition to the disease, genetic, environment, and this is very important because you know there are families which are more affected by some obstetric disease because there is a genetic trend, and also the environment may influence. You know that more preterm birth are happening when there is a climate that is very hot and very humid compared when it is very cold and dry. And many clinical manifestations are adaptive in nature. So this means, for instance, that for preterm birth due to infection, the nature tries to save the mother in getting out the fetus, because with an infection, the infection of the amniotic fluid and the uterus can kill the mother. And it is very important to maintain for our maintenance of a species. So there is nowadays, in the last at least 20 years, accumulating evidence that many diseases which are characterized mainly by symptoms or signs, for instance, miscarriage, preterm labor, rupture membranes, the preeclampsia, as I said, small for gestational age, large for gestational age, even abruption of placenta and so on, should be classified as syndromes. And they have, as you will show in a moment, very common pathways. What is happening, in fact, is that all these syndromes recognize something defective in implantation and placental formation. The problem is the interaction between the maternal body and the fetal and the trophoblast aggressiveness to enter in the maternal body, okay, which may do different phenotypes. We may have placental insufficiency with preeclampsia, without preeclampsia. We may have abruption placenta because the mother has thrombophilia. And these are, however, basically recognize very similar pathways. Okay? I will show in a moment. The major, most important feature of pregnancy to start and to continue are implantation and the formation of placenta. Implantation recognizes a big shift in the maternal immune system, which is called immunotolerance, because the success of a pregnancy depends upon a tolerance of a genetically incompatible fetus, because the fetus is made by paternal and maternal chromosomes. It's not the same as the mother. And this implies modification in maternal body, particularly to tolerate like it is a sort of allograft. In fact, we are considered partly a sort of allograft, which change immunity in a sort of adaptive immunity. And in order to have this change of immunity in the body of a mother, progesterone should be rising in order to promote the production of a compound, of a substance which is called progesterone-inducing blocking factor, particularly from the lymphocyte and the decidual cell. This factor promotes the protection of the embryo and the fetus against, the antibodies or the cytokines which may affect pregnancy and try to eliminate an allograft, because everything which is coming in our body is eliminated by our immune system. But the progesterone is shifting this in order to mask the embryo and the fetus and to decrease the aggressiveness of macrophage and so on. So at the end, what is happening is that in the system of the mother, we have the shift from Th1 to Th2 lymphocyte predominance. Then we have a decrease of natural killer cell, particularly in the pseudo-trophoblast interface. And finally, we have antibodies which are not reacting against the embryo. And this is due to the concentration of progesterone. The second step is the placental bed formation. And the placenta formation depends mainly by what we call the neoangiogenesis, so the production of new blood vessels, which is under control again of some special factors, VEGF and so on, which should be balanced against those which are producing a counter angiogenesis, so they are blocking angiogenesis. So it's always a pro-angiogenic, a contra-angiogenic balance. And one of the factors which is controlling all this is placental growth factor, PIGF, which regulates placental vascular development. But there are other factors like PAPA also is doing the same. The balance between angiogenic and anti-angiogenic factor is the key to have a normal placental development. And the normal placental development for the uterine blood flow, uterine placenta blood flow, is given by the effect of estrogen and progesterone again. So progesterone again is crucial in order to counteract the activity of estrogen, which are promoting a increased neoangiogenesis. Also testosterone has some effect, but usually in blocking the angiogenesis. So you see, this is a complex mechanism, and in the meantime, the trophoblast is entering in the artery of the uterus, the so-called spiral arteries, producing a derangement of the muscular mucosa, so the muscles of the arteries, destroying this muscle until the basal membrane. Why he has to do this? Because otherwise the circulation of the placenta respond in the same way to vasoconstriction, vasodilation, while the placental circulation should not answer to any vasodilatory or vasoconstrictive agent. And this is very important. Unfortunately, in some cases, this invasion is not complete, it's only partial. And unfortunately, the vessels are vasoconstricting. Vasoconstricting in a very low flow development of vascularization, like in the placenta, bring an increase of atherosclerosis. And this atherosclerosis is closing the vessel. What does a mother to counteract this closure? Increase blood pressure. And this is the manifestation, for instance, preeclampsia. So you see that everything is coming from the placental bed formation. The key issue in this placental bed formation, this you can see, I just published in Gynec Endocrinology a very recent review of all these factors, is given by the oxidative stress. So implantation, which is mainly dependent from maternal immune system, and placental bed formation, which is mainly due to the new vascularization, are in any case increasing oxygen tension because of new tissue which are forming. These bring an increase of oxidative stress. Now what is happening? Normally, in a normal body, where we have adequate antioxidant defense because the mother is has a normal lifestyle, the organism is balanced and so on, they counteract the oxidative stress and they resolve the progressive problems of intravenous blood flow, bringing normal placental function. But when the oxidative stress is not balanced properly, because the mother suffers of metabolic disorder, or there is mitochondrial dysfunction, or there is a lifestyle which is not appropriate, obesity, malnutrition, and so on, the oxidative stress is not counterbalanced. There is a major risk of either complete degeneration of a syncytial thromboblast, which brings to what we call miscarriage, or we have ischemia reperfusion, we bring to chronic oxidative stress, which is what we call placental insufficiency. So practically, the key problem in the pregnancy, which is affected by after implantation a placenta bladder formation, is oxidative stress. Now, all these obstetrical syndromes are poorly still understood because we don't know all the picture of the etiology. Diagnosis, therefore, is not simple, and the methods to treat are still debated. Results, of course, are not, frankly, predictable, and, of course, the cost of preeclampsia, preterm birth, miscarriage, so on, are still very enormous, not only in medicine, but in the society. Now, let me address one obstetrical syndrome which we usually are characterizing like two different diseases, miscarriage and preterm birth. But miscarriage and preterm birth are not different diseases. They are the same obstetrical syndrome. Why? I will show in a moment. The only difference is gestational age, but they recognize the same risk factor. For instance, before pregnancy, I can define which are the women which have a major risk of having either an abortion or either preterm birth. So what we call shortening of pregnancy. Pregnancy is not going to term. For instance, the age. We know that when a woman is too early, teenager, or is over 40, they have the same risk of having abortion or preterm birth. If there is some ethnic groups which are have a more incidence of abortion and preterm birth, for instance, black population. Okay? Then we know that there are diseases in the woman, like for instance polycystic ovary syndrome or endometriosis, which are linked to major risk of either abortion or preterm birth if pregnancy starts, apart the difficulties of fertility. And the same, some medical disorder like thyroid dysfunction or diabetes, they are linked either to abortion or preterm birth. And again, if a woman suffered of a previous abortion, she has again a major risk of abortion, but also preterm birth. And vice versa, if she suffered of preterm birth, she has a major risk of abortion or preterm birth in the subsequent pregnancy. So you see that there are several factors which I may identify. And one more important is lifestyle and BMI, because BMI is, especially obesity, is linked to major risk of abortion, but also preterm birth. What are during pregnancy the major risk for abortion, preterm birth? The pathways are very similar. They are stress, we know very well. CRH, very stressful situation, increased prostaglandin production. And from prostaglandin production, according to gestational age, I can have an abortion or preterm birth. Cervical insufficiency. If it's too early, comes an abortion. If it's late, comes an early preterm birth. Uterine overdistension, twins. Twins are linked to more abortion and also to more preterm birth. Uteroplacental ischemia, if it's very, as I said, the oxidative stress is very high, I have abortion. If it's middle, I have placental insufficiency and major risk of preterm birth. And finally, of course, inflammation, infection that during pregnancy can, cause both according to gestational age. So the real difference from, the abortion and preterm birth is only gestational age, because also the final activation of a uterus contraction, the ripening of a cervix, rupture of membranes are similar mechanisms. Okay? So there is only one syndrome. Abortion and preterm birth, they are together. The only difference is gestational age. In one abortion, we don't give capability to the fetus to survive. In preterm birth, we recognize that the fetus may survive, of course, with some help, for instance, by neonatologist. This is the only difference. And all these risk factors are amenable for prevention, or at least for management. There is one risk factor we cannot change, and is the sex of a fetus. If we have a boy in the womb, we have major risk of abortion and preterm birth compared to have a girl. You should know this. 2/3 of abortion are for male compared to female. And 60% of preterm birth are for boys than for girls. And you know also that if a girl is born preterm, she has more chance to survive better than a boy, unfortunately, because maturation of a lung is later in the boys. This is due to something that we are not used to think, that the placenta is different between boys and girls. The placenta is not the organ which is the same in every pregnancy, either if there is a fetus which is male or female. The placental of male fetus is different from the placental of female fetus. For instance, the female placenta is much more protective, immunoprotective for the female compared to the male. Many infections which are coming to the mother, like CMV, Zika virus, and so on, are more affecting the male fetus than the female fetus. And therefore the consequences are more for the female. So that is to say, the nature privilege in the womb, in the pregnancy, privilege women and not the men. So the strongest sex is the female in pregnancy, because of course to maintain our generation we need a female, we not need too many males. And if the males should be good, and therefore they can be discarded if something is wrong. This is what is happening in nature. Then the male, when he's born and grow up, think that he's stronger. But for the beginning of life, is not that stronger, for sure. The strong sex is only the female. This is to pay a tribute to the mothers, which are the strongest, of course, among all these. Now, let me come back to now our hormone, which is the most important hormone, as I showed before, either because regulate immunotolerance for implantation, either because regulate the placental bed formation. It is progesterone. In this issue of the British Medical Journal, which is best practice in clinical obstetric gynecology, I and Dr. Piet wrote these several chapters of this, and you can find is also translated in Vietnamese, so you can download free from the website. Okay, and this we summarize all the action of progesterone and its metabolites, because you should remember that progesterone, when it enters in our body, it doesn't remain as it is. It is metabolized in several products, and some of them have action to modulate the maternal immune response. Some are desexualizing the endometrium. Some are counteracting against prostaglandin. They are very potent anti-inflammatory agents and so on. Progesterone is a steroid substance. It's very similar to corticosteroids. And corticosteroids are anti-inflammatory agents. So it's very similar, very conceivable that progesterone is a potent anti-inflammatory drug, which is important because in pregnancy the status of the mother should be against inflammation, because inflammation promotes eventually the delivery. And you see the pathologic inflammation, which is what is happening when in our body is happening something. For instance, the construction of new vessel implies oxidative stress, implies inflammation, is counteracted by the presence of progesterone and its metabolites. And this is very important to understand. So whenever we have a good amount of progesterone, this means that there is an anti-inflammatory action which is counteracting what is happening in pregnancy. Okay? So let's divide now again the syndrome which I spoke about in miscarriage and preterm birth, of course, because we have two different gestational age we are talking about. Now, the most important things to know is that compared to preterm birth, the first part of pregnancy, the first 12 weeks, if pregnancy stops, is mainly due to genetic problem of the embryo. So the majority of the reason why a pregnancy stops in the first trimester is because there are chromosomal abnormalities or gene abnormalities in the fetus. Okay? However, this percentage is maintaining more or less even in the subsequent pregnancy. So, if I have more abortion, the reasons which are not chromosomal, not genetic, are prevailing. And this is why we may notice more action of our intervention after the second or third abortion than in the first one. Because in the second and third, there is at least a more statistical significant action of the hormones in trying to prolongate the pregnancy. And this is very important to understand, because the study which have been done until the last 10 years were not considering that almost 30 to 40% of pregnancy is completely unuseful to give anything, because if there is a chromosomal abnormalities, they will abort it in any case. So the first two big studies, which are comprehensive of big number of women, more than 5,000 women altogether, are these studies which also consider very high amount of progesterone to be given. Because from the basic study, from the study in the beginning, especially in IVF patients, it's been shown that in order to reach meaningful level of action of progesterone, either in the genital tract, either concentration in the blood, you have to raise the amount of progesterone to administer at least to 600 milligrams a day. So in the past that we were giving 100 milligrams a day for preventing abortion, were not possible to have any result because the progesterone was too low. The concentration was too low. So you see that nowadays we give 800 milligrams a day at the beginning of pregnancy, because the immune action of progesterone needs very high level of progesterone. And these studies show that when we have more than 3 abortions, we protect pregnancy, we have more live birth. So practically, if we have one patient which has a story of abortion, and even she has symptoms, or she has what we call a recurrent abortion, we can give progesterone high dosage, and we have 20 to 30% less risk of abortion. And this is the final result. You see that the numbers are meaningful. This is the meta-analysis of the data. We show a gain of at least 30%, as I said, in live birth using micronized progesterone, 800 milligrams a day. So these are the data which are summarizing the major study which have been produced. Nowadays, our Bible, which is the Cochrane, you know, the best practice, best evidence, has put together 7 randomized controlled trials, and the only substance which may affect the result of a miscarriage abortion is to give vaginal micronized progesterone. Because we have meaningful result either in patient with history of abortion, either a patient with the symptoms, but we have a previous abortion. And this is coming out also in the guidelines, for instance, the NICE guidelines. So all the guidelines in the last 2-3 years have updated the Royal College, American College, whatever, that progesterone is the best offer we can do to our patient to decrease by 30% of a risky abortion. No other drug has been shown to have a similar effect. This is written also by the NICE, which are, very good. Now, safety, of course, is important because you may say, I give a very high concentration of progesterone. Does it affect the embryo development? No. 800 milligram, even 1 gram 200 is safe. This is a lot of study which has looked to the risk of congenital abnormalities and also the follow-up of the baby up to 8 years old. No effect on neurodevelopment, no effect on the growth of this baby, given high dosage of progesterone at the beginning. And you know now, in fact, that the quality of evidence of progesterone, which increase live birth in women with recurrent miscarriage, is medium to high compared to many other action that we still do, which have a very low evidence. For instance, to give a thyroxine to those which are hypothyroid, and we give because hypothyroidism is affecting the length of pregnancy, is not so substantiated as progesterone. And the same when we speak about antiphospholipid syndrome, we give aspirin and low molecular weight heparin. But if we look at the evidence in the literature, it's not so high as the one in progesterone. So we have much more evidence nowadays that progesterone is working. Now let me shift to the second part. It's the same syndrome, what we call preterm birth, because it's coming in a period in which there is a possibility for the fetus to survive. So we call birth. If it's not capable to survive, it's abortion. Now, preterm is important to prevent preterm birth, because if in abortion I don't have anything except the effect to the mother, because of course there are psychological problems in the mother, there is much more risk of depression, sometimes of course there is bleeding and so on. But for the preterm birth, the baby is born. It may have a morbidity, it may have very severe handicaps. So for the society, it's very important. And also it may die after 1 year, 2 years, or have many problems. So I think it's very important to know that unfortunately, until now, we don't have a very good methodology for prediction of which is the mother at risk of preterm birth. We can have the cervical length that nowadays is applied almost everywhere in order to try to distinguish between a patient which have a major risk. But we identify only 2% of women. And in many countries, the rate of preterm birth is 7, 8, 10%. So what is happening to the other 6%? How we may identify them is not easy. And also, the acute presentation is different. If the mother has symptoms, we may measure the cervical length, we may measure some solute like fibronectin or IGF-1 and so on to identify better who is really in labor. But still, the most important is to try to predict earlier. There are now new tests, and of course there are some of the risk factors which may prevent. For instance, one of the things you can do is to change the lifestyle in women which are abusing of smoking, of some toxic alcohol or so on. You know that nowadays everybody is in agreement all over the world that stop smoking, stop alcohol should be the rule in any pregnancy, because there is no real, kind of cutoff that can be, permitted to the woman not to avoid the risk of preterm birth. So we have to say to the woman, stop everything. And also for the lifestyle, we have to try to make a very good eating and diet and supplementation. Because nowadays we know also that if I had omega-3, you eat at least 2 or 3 times fish per day, probably in your country, like the Philippines, Japan, and so on. But in many countries in Europe and in the United States, they don't have this tradition. They eat more meat. And unfortunately, omega-3 are not the one in the meat, are the one in the fish. And the DHA particularly is important. Nowadays we have just raised guidelines which show that if we appropriately have supplementation of omega-3 from the first trimester of pregnancy, we decrease 40% of preterm birth rate. 40% less of preterm birth rate with an appropriate supplementation of omega-3. The figure recommendation, which started already in 2015, and they have been reiterated just 2 years ago, show that it is important to measure the cervical length, of course, but we only identify 2% of women, and in this case, if there is a short cervix, which we say that is less than 2.5 centimeter, we should give progesterone. In this case, vaginal micronized progesterone is only 200 milligrams. Why? Why not so much like before? Because in the first part of pregnancy, progesterone is working in the immune system. In this part, progesterone given by vaginal route is an anti-inflammatory action against the risk of the cervix to be, let's say, opened or shortened by inflammation, by infection, or by other reason. In any case, the action of progesterone is mainly local. And you know that the universal screening of a cervix, you can do at 20 weeks, 22 weeks when you do the anatomic scan, which is now done everywhere, almost in the world, at least in middle to high income countries, is very good number needed to treat, because compared to other screening that we do, for instance for cervical cancer or for the breast cancer, we need a much more number of patients to save one case. In this case, we need to do 200 screen of cervical length, and we prevent preterm birth. So the meta-analysis which have been done recently have shown that there is no need of any further randomized controlled trial to adopt the progesterone as the main preventive agent for preterm birth. So there is now compelling evidence when progesterone works. And you know that the benefit is not only in reducing the risk of preterm birth, but reducing also effect on the newborn. Reducing birth weight, mortality, admission to neonatal intensive care, and so on. So this means that progesterone really is affecting the pregnancy, not only length, but also the pregnancy outcome. And prenatal vaginal progesterone is not associated again with any cognitive or psychopathological findings in twins or in any other singletons which have been tested for 9 to 10 years after birth. So this is a safe compound to be given. And in order to compare with other interventions we do, you see the number needed to treat is particularly important. We need at least 12 to 20 patients giving vaginal progesterone in the case of short cervix, which is very similar to the number we give when we give antenatal corticosteroid to avoid respiratory distress syndrome or neonatal death in a preterm birth labor. But is much less than giving magnesium sulfate for neuroprotection and much less of aspirin given for prevention of preterm birth. So, for the prevention of preterm birth, you need to treat less patients than aspirin to get better result. Okay, so progesterone is much more in action. Recommendation, this is I take one, International Society of Ultrasound is recommending vaginal micronized progesterone either in singleton pregnancy, which have been previously having a spontaneous preterm birth, either in a symptomatic singleton pregnancy with short cervix, less than 2.5 centimeter. So these are grade of recommendation which are very high in both cases. Do we have to use any other compound which is similar? You know, in the United States, they propose to use 17-hydroxyprogesterone caproate, for instance. But according to the data which have been collected, either 17-progesterone caproate, either dihydrogesterone, they have no effect on pregnancy prolongation, no effect on reduction of miscarriage, no effect on increase of live birth in different randomized control trials which have been published, but instead they show safety concern, both drugs. Either 17-hydroxy, in which there is an increased incidence of gestational diabetes and even of tumors in the newborn, or by dihydrogesterone, which increases the risk of fetal cardiac and genital defects. Now there are many studies which are, challenging these two products to be used, and particularly ESRE, the European Society of Human Reproduction, has put a word of caution in using dihydrogesterone, particularly at the beginning of pregnancy, because there are some concern, as you see here, regarding safety for the offspring. So if we have two drugs and one is safe and the other is still unclear, of course everybody should use the one is safe. So my idea is to forget the monoprogestin until we have at least more data and come back to our microneedle progesterone. Now, as I told you, for the syndrome of abortion and preterm birth, the indication of concentration of progesterone to be administered are two. For the abortion, for the first part of pregnancy until 16 weeks, give at least 800 milligrams of progesterone, 200 milligrams twice a day, and for the after the 16 is to give 200 milligrams every night until 36. In this case, if you continue and give progesterone for all the pregnancy, you avoid the risk of abortion and you avoid also the risk of preterm birth. Why? Because I told you, if the patient had the previous abortion, if I give progesterone and I stop 16, I avoid abortion, but I don't avoid the risk of preterm birth, which she has. And if I do the vice versa, it's the same. So even the European Society of Human Reproduction recognized that every woman who has an abortion has twice as much a risk of preterm birth. So it's better to continue progesterone until 36 weeks. Then I want to finish with a new panorama of indication. Because I told you, obstetrical syndrome are mainly due to a similar pathway which recognizes placenta disorder and lack of implantation, of normal implantation. So normal implantation, uterine receptivity, decidualization, placentation may result in what we call placenta-related disorder, which are the obstetrical syndrome. Now, in a very recent meta-analysis of 11 randomized control trials, this group in UK demonstrate that progesterone given early in pregnancy, 800 milligrams at least until 16 weeks, may prevent preeclampsia. May prevent preeclampsia if it's initiated in the first trimester. And these are the results. You can see the randomized trials are very nice, and that there is a decrease of 30% of preeclampsia in all kinds of preeclampsia, either early and late preeclampsia. So giving progesterone, you're already decreasing the risk of preeclampsia in this patient. So if you are protecting for abortion, if you are protecting the patient for preterm birth, you should know that you protect the patient also for preeclampsia. Why? Because the placental formation is crucial for all the three diseases. The pathway is very similar. And to show this, I show a very recent study which is based on the predictive value of PAPEI. PAPEI is used at the beginning of the first trimester along with the beta-HCG and nuclear translucency to detect the risk of genetic disease in the fetus. We will call the so-called combined test, nuclear translucency plus two solutes. But the PAPEI alone has been always associated with more risk of preeclampsia, preterm birth, treated abortion. So, if we look at papain is depending from progesterone. If I stimulate the cell with the progesterone, I produce more papain. If I block the cell with the anti-progesterone receptor, RU486 mifepristone, I block papain. And papain is a marker of placental formation. Now we did a study looking to pregnancies which have very low papain, which have been selected from these patients who do screening with a nuclear translucency and B test. We select patients with a very low median of papain, less than 0.4, and we divide in 3 groups. Of course, this patient has been cleaned up with a chorion-Villa biopsy for any chromosomal disorder of fetus. So they are normal pregnancy, but a very low papain. We give progesterone at the beginning until 16 weeks. In the second group, we give progesterone for all pregnancy. In the third group was only control, no progesterone. And which are the results? The results are very clear. In the group with no progesterone at all, I have almost 75% of pregnancy which stop as abortion or preterm birth. Very low birth weight, and the pregnancy duration is low. If I use only to give progesterone for only 16 weeks, I decrease the miscarriage risk, but I don't decrease the rest of the risk like preterm birth and fetal growth restriction. But if I give progesterone until the end, I have a big decrease of all this risk. So this means that if I have an indicator in first trimester to start progesterone, and I give progesterone, I do even better than to give aspirin. So my conclusion is that we have this syndrome now. We have to call syndrome some disease of pregnancy. And abortion and preterm birth are together. Why? Because they recognize similar risk factors, they have similar pathways, and at the end they have the similar way to expel the fetus. The only difference is gestational age. Okay, then there is of course a different incidence of chromosomopathies because abortion has more chromosomopathies of a fetus compared to preterm birth, but this is another problem. The risk factors are very similar. Now, we have already written, and this is the foreword, a very recent book that you can download free from the Global Library of Women Medicine in London, we produced 2 years ago, in which the interaction between the more risk factor and the mechanism of expulsion of the fetus is because maternal homeostasis and adaptation or maladaptation to fetal allograft determine the earliness or lateness of the event. Okay? Since pregnancy is a continuum, if this happens as 20 weeks or 18 weeks or 15 weeks as abortion, if it happens 24, 26, 28, we call preterm birth. But you see, the fact that it is a very similar mechanism is confirmed by the fact that a substance like progesterone is effective to prevent both miscarriage and preterm birth. And I think that this slide summarizes what we know nowadays, what we can do for prevention of the so-called great obstetrical syndrome. So miscarriage, preterm birth, preeclampsia, IUGR, rupture membrane, stillbirth, abruption placenta. We cannot, of course, fight too much because we have to still study the mechanism, biological basis, and some factors which are not available of prevention. But nowadays, the best practice is giving progesterone, short cervix, previous preterm birth, progesterone for miscarriage and recurrent miscarriage, aspirin for preeclampsia, omega-3 for preterm birth, multivitamin supplementation, folic acid, iron, so on, also because these improve pregnancy at term, eliminate maternal smoking, spacing the pregnancy at least 1.5 years between one pregnancy and the other. You know that if we are too short, we have an increased risk of abortion and preterm birth, decrease cesarean section rate. Cesarean section, particularly cesarean section in the second stage of labor, is increased by 50% the risk of a subsequent preterm birth. And even normal cesarean section increase the risk in a subsequent pregnancy or preterm birth. So remember that the cesarean section is a risk factor for preterm birth. And finally, of course, we have to be careful in assisted reproductive technology to transfer only one embryo and not to create many twin pregnancies. So all these factors are recognized now by evidence medicine, which are decreasing the risk of abortion and decreasing the risk of preterm birth. The simple one and the most safe one is by far to give progesterone. And with this, I think that I am very thankful that and open to any question you may have. Come on, thank you very much.
Xin trân trọng cảm ơn phần chia sẻ rất thú vị từ giáo sư Giancarlo Di Renzo. Kính thưa quý vị đại biểu, tiếp theo chương trình là phần chia sẻ từ bác sĩ chuyên khoa 2 Phạm Hồ Thúy Ái, trưởng khoa hiếm muộn, nguyên trưởng đơn vị kỹ thuật chẩn đoán Bệnh viện Từ Dũ với chủ đề cập nhật từ Eugene 2026, hiệu quả của giai đoạn âm đạo chứa Coriolis versicolor trong gia tăng đào thải HPV nguy cơ cao, kết quả từ nghiên cứu ICT Paloma 2.